Thank you, Bob, and thanks for being on time. The last pearl in this wonderful, wonderful session is new observation of the role of autonomic nervous system in arrhythmogenesis by Dr. Doug Zipes. Doug will appreciate if...
I'm starting when I'm supposed to be finishing. I'll see if I can make a 20-minute talk into 10. So my presentation is on the autonomics, and we know that there are certain clinical situations where the autonomics play a clear role. So for example, the morning increase in mortality, stroke, and thought perhaps related to the catechol release upon rising. However, more recently, a clock-dependent oscillator, a genetic control, may affect a potassium channel that indeed may be responsible for the increase in mortality in the morning, and it may not be autonomics. But fascinatingly, we also know that there's increased sudden death in winter months. This occurs in adults, infants, in dogs with myocardial infarction, regardless of the weather, and in Australia during June, July, and August. And the question is whether there's a seasonal oscillator that increases mortality in the winter. Winter months are associated with elevated blood pressure, longer QT, and lipids. And these are other examples that might be autonomically modulated. And then finally, we know that there's increased sudden death after stress, such as natural disasters or personal loss. And this has been labeled Takayasu cardiomyopathy. Patients may present with profound T-wave changes, and long QT has been described with torsade and an increase in ventricular arrhythmias from stress-induced cardiomyopathy. So how do the sympathetics, presumably playing a role here, modulate cardiac activity? They may do it by autonomic heterogeneity and by triggering cardiac arrhythmias. Let's look very briefly at one potential mechanism. If the sympathetics are traveling to the ventricle, as shown here in a sagittal view, and there is an interruption such as myocardial infarction, there may be downstream denervation that may occur in otherwise normal myocardium with subsequent hyperinnervation, nerve sprouting, and cardiac arrhythmias on that basis. And I will demonstrate that in this image in a patient post-myocardial infarction who had normal left ventricular flow measured by N13 ammonia, but clear sympathetic denervation, as you see here with C-hydroxyephedrine. This then can produce heterogeneous responses and cardiac arrhythmias. And I will skip through some of these slides that document exactly what I've said in the interest of time, and move to this particular example, which is very important. These are recordings in a dog post-myocardial infarction, recordings of stellate sympathetic innervation and vagal nerve activity. This is control, and 2 days after the infarct, you see an increase in sympathetic activity while vagus is staying relatively flat. 1 month after myocardial infarction, there's still a greater increase in sympathetic activity while the vagus is still staying flat, and increasing even more 2 months later. And my slides are not advancing. There we go. This simply documents the increment of sympathetic activity. The thing I want to emphasize, however, that in addition to the functional changes, which I just showed you, there are anatomic neural changes that occurred following myocardial infarction. So here, for example, are histologic presentations of the left and right stellate ganglia before and after myocardial infarction, and there is an increase in neural activity in the sympathetic ganglia and in the action of the nerves post-myocardial infarction. So the infarct is not only producing dynamic changes, but histologic changes of the nerves going to the heart. And that's the important point of that. We know that modulation of sympathetic activity can reduce cardiac arrhythmias. Some treatments are not that new. For example, I published this paper 43 years ago of a patient with recurrent ventricular tachyarrhythmia that was treated by bilateral surgical sympathectomy with elimination of the arrhythmia. This has been perfected by Peter Schwartz and his group, interrupting stellates, a patient with CPVT showing the effect of left stellate interruption, and now can be done by thoracoscopic approach, minimally invasive, interrupting the sympathetics. And I will move to, let's skip this one, and I'll move to the last points that I want to make. This simply shows modulation of atrial fibrillation by vagal stimulation in an animal model, but I want to conclude with the very important concept that vagal nerve stimulation modulates sympathetic activity and can thus impact the development of ventricular arrhythmias. And why is that important? Can vagal nerve stimulation treat ventricular arrhythmias and potentially heart failure as well, which we know in heart failure there's an increase in sympathetic innervation modulating cardiac activity, and vagal stimulation can affect all of these potentially adverse changes. This can be done by cervical vagal stimulation, which is using the CardioFit stimulator and has been used in patients with heart failure. This is the first study by Schwartz's group, a group of patients with New York State class heart failure. During vagal stimulation, the majority of them improved. And I want to concentrate on these last few slides, that is spinal cord stimulation. We've demonstrated that spinal cord stimulation at a T2 to T4 level is vagomimetic and or sympatholytic at the heart. And therefore, spinal cord stimulation might be used then to treat ventricular arrhythmias. We demonstrated this in an animal model in which we produced an infarct to create a scar, rapid pacing for heart failure, and then occlusion reperfusion to produce transient ischemia. These dogs develop ventricular arrhythmia, and we demonstrated that this is in control. 13 of these dogs developed VTVF, 9 did not, and then during spinal cord stimulation, you see a reduction of spontaneous ventricular arrhythmias. And we tested this in a longer model of 5 to 10 weeks, and these data are published just to show you the results. So this is the blood pressure effects. We have 4 groups: spinal cord stim plus meds alone and control. This is normal. This is after heart failure and myocardial infarction. And you see after 10 weeks, the spinal cord stim dogs return back to control. In addition, if one looks at heart rate, dogs become edematous with their heart failure. The spinal cord stim dogs return back to control. This is serum BNP, which increases very dramatically. The spinal cord stim dogs come back to control. This is serum norepi, increases dramatically. Spinal cord stim dogs come back to control. This is left ventricular dimensions. Systolic were similar. Dogs develop cardiomegaly, and spinal cord stim come back to control. And then this is ventricular arrhythmias. Dogs develop VTVF. Spinal cord stim dogs come back to control. And then ejection fraction starts out as normal, goes down to 18%. Spinal cord stim dogs come back to control. Based on these data, we wondered whether spinal cord stimulation at the T1 to T4 level improved cardiac contractile function, decreased ventricular arrhythmias in the dog. We wondered whether the same thing might happen in patients. And indeed, this is the study. These are just my last few slides. The study in patients now of spinal cord stimulation in patients with heart failure. It's called, whoa, I'm not that fast. It's called Defeat Heart Failure. Heinz Perez, PI in Europe, I in the US. And it is implanting this multi-electrode lead in the epidural space of patients and stimulating at a T1 to T4 level with this implanted stimulator. Patients are stimulated 12 hours a day. This is at 50 hertz with adjustable voltage output. These patients then are, the objective is to establish whether reduction in left ventricular end systolic volume index can take place after 6 months of spinal cord stimulation. There's some secondary analyses. These are patients with EFs of 35% or less. They qualify for an ICD, and we've shown no crosstalk between the two devices. New York Heart Functional Class 3, QRS less than 120 milliseconds, left ventricular dilation, stable medical management. We have 23 sites. Study goal is 70 patients, and we're almost there. We hope to finish this study within the next couple of months and be able to demonstrate that spinal cord stimulation then reduces heart failure and ventricular arrhythmias in patients. There are other autonomic studies that are being tested as well. And if successful, vagal nerve stimulation directly or via the spinal cord can reduce ventricular arrhythmias, improve left ventricular function, providing a significant advance in treating patients with heart failure. And I'll stop at that point. Thank you very much.
Thank you. Thank you, Doug. If you please remain on the stage and you can have the other speakers come up, we're going to do a presentation. I want to thank all of the discussants. Doug, you can stay on the stage. And all the other speakers come up. I want to thank everyone for participating in this joint session of the American College of Cardiology Israel Heart Society.